friends and dear colleagues here, panelists, and all attendees. Good evening and good morning, wherever the participants they are following us. Today we are having a very interesting topic that we are facing all the times, and sometimes it's a nightmare. It causes us a nightmare when we cannot deal. And I think one of the most difficult and long period of time to take a patient. I mean, you have to be a patient as a doctors, and the patient to be himself a patient to be treated. Corneal ulcer from A to Z, as I mentioned in our invitation. We are having today a very eminent speaker. They are going to cover this topic nicely. Most of them, they are well experienced, and you will listen to them about the tics and pros and cons that you can benefit from this presentation and their experience. As far as I know, I have reviewed a little bit some publications. Corneal ulcer in United States, about 35 to 75,000 annual patients they are having a corneal ulcer, which is represent about, as I do remember, about 12% of those they are underwent a corneal transplant. The corneal transplant, 12 of them they are due to corneal ulcer complication, and they are needed for PKP. Before that, we are having also my dear friend, Dr. Hayat Khan. He is going to talk about something introduction for a dryness. Just 1 second. So Dr. Hayat is going to be the first speaker today. Dr. Hayat, he is head of pediatric ophthalmology, senior specialist registrar and pediatric ophthalmology, Dubai Hospital, Dubai Health Authority, UAE. He is a well-known also figure of now, I mean, in pediatric in United Arab Emirates. I think he will move after a while to another place from Dubai Hospital. Then maybe this I can keep to him if he want to say that. So Dr. Hayat, the mic with you, and you can start the presentation. Thank you.
Thank you, Dr. Amri. So kind of you of your kind invitation for this esteemed gathering, and my esteemed colleagues, I would like to say Assalamu alaikum to all of them. And I would like to start this interesting presentation, dry eye management from a different scope. Now, if we just go by the definition, dry eye, as we all know, is a multifactorial disease of ocular surface. And it has a characteristic of having a loss of the hemostasis of the tear film, which covers the eye surface. And necessarily, it has to be accompanied by ocular symptoms. And in this, for sure, there is a couple of things which are important. That is, there has to be an associated tear film instability, hyperosmolarity, ocular surface inflammation and damage. And lastly, now we have included the neurosensory abnormalities to be a part of this. Now, in this particular presentation, I would be using the dry eye disease as often as you can see. Now, pediatric eye disease, being a pediatric ophthalmologist, I would like to first come to the pediatric age group. Of course, we sometimes feel pediatrics, well, they may not have dry eye, but no, it's not true. It is a not very well understood disease because of poor cooperation, lack of symptom quantification and interpretation. The children are not really so much cooperative in terms of the examination, and that leads to underdiagnosis and a neglected point of view from most of the ophthalmologists. Now, previous studies before this COVID pandemic stated up to 25% of the population, pediatric population, having this disease. And the key causes at that time, as enumerated, would be the congenital anomalies, the autoimmune diseases, in which I would be taking up one particular case where you have Sjogren's, grass versus host disease, juvenile JIA. Ocular allergies are pretty notorious in a long-term basis. not only as a disease, but also in part of the treatment. As we give treatment, they cause dry eye. The medicines itself are accumulated to some cases I've seen in my practice. Now, very importantly now, especially with this pandemic and children being at home and all the school studies are now going on screens, this has erupted the number of cases of dry eye disease in children, as I see at my clinic, as at an enormously high number. And usually the lacking phase is that the symptomatology, kids do not really tell the parents. So you have to, rather than going to do the kids, you have to ask the parents that, do you see a change in the behavior? And a lot of mothers will tell us that, yes, there is a change of behavior, because they stare at the screens. And specifically for that, I would like to start with saying to my audience that every time you have kids, if they're using their mobile devices, ask them to pair it to the television, and at least the television is far. So that not only improves the dry eye disease, but also it improves the decrease the chances of increase in the myopia also, because the patients will not be accommodating and converging all the time. Now, having said that, this is now a major issue for which I always tell a rule of 20, that at every 20 minutes, a patient should be looking at, if there is a window or something, people should be looking out, taking a break of at least 20 seconds. And that would ease up, and blinking habits would definitely improve the overall, this problem, which is now coming up. And not only they will be suffering now, but as they grow up, our colleagues who are into adult practice will come to know that there will be a huge impact of this, especially this screen time, that increased screen time now the kids are having. Of course, iatrogenic and the vitamin deficiencies are also implicated. So now I'm straight away going on to a 7-year-old girl with severe painful right eye, which presented to me. She had a bone marrow transplant, which was about 10 months back. And she has this problem of painful eye, which is off and on. And on examination, this is what we got. Both the eyes, almost a similar picture, but definitely there was a filamentary keratopathy in the right eye. And this actually gives us that this child is suffering. We had to debride these filaments. And then, of course, we came to the diagnosis that this is a graft versus host disease. And therefore, I'll just go straight away to this discussion of what it is. So usually most of these children have transplantation due to malignancy. And these grafts are also because of sometimes bone marrow failure, immunodeficiency, metabolic diseases, and so on. And what we know is this is the curative approach, and it is at least 4,500 of these procedures are happening every year in the US in children less than 20 years of age. And out of all these children, 40 to 90% of these children, they go into a chronic graft versus host disease, and they develop ocular symptoms. Now, these are the patients, if we do not identify and treat, can be a big problem. And that's the kind of case the patient had gone to several clinics and nobody could actually diagnose, with the reason that the poor cooperation and some of the characteristic features were missed out. But alhamdulillah, when they came to us, we were able to identify them and treat. Now, going further, as we go on to the etiopathology, it's poorly understood, but the donor T cells have the implications in this particular disease, and a decreased conjunctival globulate cell density, which causes the conjunctival squamous metaplasia, causing a decrease in the tear film aqueous layer, is the key thing that you will be looking. Not only that, there will be inflammation, and that will be associated with infiltrates and lymphocytic infiltration into the epithelial cell, causing necrosis. So in presentation, you can have a whole array of all these different findings. I'm not going in, but out of this blepharitis, that's what I saw this child having. There was, of course, filamentary keratitis. There can be marginal keratitis. There can be even corneal ulceration, neovascularization, as you see in one of the slides I've borrowed. and conjunctival scarring. So going further, how do we go about in these cases? We have to be prudent and not leave the child without doing a proper examination. History taking and examination are key to making the correct diagnosis and making sure what is the etiology. So a Schremer stress, a breakup time, tear osmolality, if it is available, of course, can be done. Corneal sensitivity has to be checked. Tear film microscopy and confocal microscopy, if available, with other biopsy and cytology, can be done. Now, very simple tests can be done. Sometimes we all feel that mammography is a high tech with a high intense and expensive equipments needed for that. That's not the case. We can even use a torchlight, which is infrared, that is 850 nanometer, and we can show on after flipping the upper eyelid and the lower eyelid, and we can actually take a picture which can actually quantify the meibomian gland dysfunction, which is a key area which has to be attended. I'm going to get into this in detail later, but this is an important for specifically this particular case. In children, it is sometimes extremely difficult to know what is the situation going on with the meibomian glands. Now, of course, there is an international chronic OGVH, the consensus group, which has proposed a whole area of guidelines as whether we have to, how we have to do the Schremer test without anesthesia, the corneal fluorescent staining, and the conjunctival injection. And it has to be using the OSDI score, which is a particular chart where the numbers have to be given from 0 to 3. And then based on these new guidelines, an objective form of measurement has to be done to have a fruitful outcome. Now, in terms of treatment, most importantly, lubricants have to be preservative free. Artificial tears, there's a whole area of different ones which are available. If failed, of course, autologous serum tear can be one of the options in severe cases which are not getting better by any other means. The topical immunosuppressive treatment in the form of corticosteroid and cyclosporin, which we used in this particular case. Now, being in Dubai, we do not have, unfortunately, in our lab, in our pharmacy, we don't have a constitution of 1% cyclosporin, which would have been my choice. I used a QID dose of Restasis, which is at a low concentration, and I was able to get a good result. Of course, ribamycin 2% eye drops can also be constituted and do pretty well in these cases. So punctal plugs we had to use in one of the eyes where, of course, it was not getting solved, and it helped us a lot. Now, this is very important, specifically where there is a decreased amount of inflow of tears. Punctal plugs are definitely the best option. Now, in cases where it really is not getting better with any of the above, of course, the amniotic membrane and tarsorrhaphy can be the next level at which we can actually attend if there's an aggressive disease. Now, humidified environment, occlusive eye fare, the glasses which are covering all over and which keep the eye chamber moist, those can be very good and helpful for these patients. And of course, gas permeable scleral contact lenses can also be used. Now, this is something like this is reduced to classification in a step ladder way. This is how we have to proceed in all cases, not only with these pediatric cases, but in general, where of course the first and most important, we have to be talking about the education part, how we have to educate the family as what is the problem and how we're going to attend it. We have to change and modify the local environmental factors, which can be, of course, like we had discussed earlier in today's presentation. Education regarding dietary modification to definitely, I have seen, this is something controversial, but definitely omega-3 fatty acid supplements can be really good sometimes. potential modification of systemic and topical medication. If the patient is already having, then of course we can modify them. Ocular lubricants, of course, various types, they are available. And if meibomian gland dysfunction is present, then again, lipid-containing supplements can be given. Lid hygiene is an extremely important thing that we have to tell, and warm compressions, especially if there is a meibomian gland dysfunction. So both of these measures can take care of anterior and posterior blepharitis. Now, once this is not adequate, we go further and we go for, especially if some patients, of course, I don't see that too much in children, but if there is a Demodex related meibomian, anterior blepharitis, then tea tree oil treatment has proven to be pretty well with stringent lid hygiene. Punctal occlusions can be definitely helpful. Moist chamber spectacles can be helpful, which we have discussed. And then, of course, when we're looking at, sometimes we may even have to use steroids once we feel that there is a more of an inflammatory element which is there. And of course, if topical is not sufficient, we have to go to oral medication. And then, of course, going further, then you have the analog and autologous serum eye drops, which is one of the options, and the bandage contact lenses. And then, and in the end, of course, corticosteroid for a longer duration, and the graft with the, of course, punctal inclusion. Now, going into the meibomian gland dysfunction. Now, if we talk about the total number of cases of dry eye, I would say a majority of them suffer from these meibomian gland dysfunction. So the most important thing we need to do is, of course, we need to use doxycycline in cases which are not getting help. Now, in children, of course, it is something which we have to be reserved because it has its own side effects, especially younger age group. But definitely in adults, we can use doxycycline. But in children, we can go for azithromycin. I have seen dramatic improvement with azithromycin eye drops, which we use twice a day for 3 days. And we usually give it on an ongoing basis, several courses, 1 month apart. And I have seen very good dramatic improvement in blepharitis. Now, azithromycin with dexamethasone eye drop, which is not available, can also be used. Cyclosporin A, as I had discussed earlier, can be amazing. And especially these cases, I found they work very well. The role of omega-3 fatty acid, I feel there it is there, and the new literature has definitely pointed out towards it. And of course, lead scrub and tea tree oil. So the choice of punctal plug, I prefer to have something which is a silicone plug, and rather than the collagen ones, which are difficult to remove. And some cases where we feel that we are not able to help the patients and no other option is available, then of course, pottery is another good option, which ensures there is 100% closure that can be taken up. Now, there are several devices now available for adults, like this eyelids device, which is to give the heat to the eyelids and then a massage. And so not a very expensive, but I have not had a personal experience to use this. I wish if my colleagues would be able to tell me if any of them have that. Intense pulsed light therapy is another option. Now, I'll just go back to the very basics of this. And of course, Dr. Amri is there to let me know whenever he wants, he can stop me. So going to the basics. What is the ocular surface? If you see, we have the epithelium, then the mucous aqueous layer, and then the lipid layer. And there are different glands and cells involved, as you see there. And this pre-ocular tear film is the most important thing which keeps our eye comfortable every time we blink. It forms a nice surface that we call tear film. And a healthy tear film, as you see, has a lipid layer at the top, an aqueous layer, and then right at the bottom, there is an epithelial layer covering the cornea. And usually water evaporates about 33% of the total tear flow. But in case if the top lipid layer is disrupted, which is the case in most of the these blepharitis cases, what will happen? There will be more evaporation and there will be a smaller aqueous mucin layer, and which will cause more evaporation and of course compromise tear film. So in terms of elements and composition and the hydrodynamic factors, it has to be properly spread, and it has to be every time we are shutting and opening the lids, especially the whole layer, all the three layers have to be intact, and that otherwise it will cause tear film instability. So Dew's classification, of course, they say there are two reasons, and that's one is that we all know it is either due to the production deficiency, the aqueous is not produced well, and the other one is it is produced well, but there is more evaporation because the normal lacrimal secretion is not staying well on the tear film. And the aqueous deficiency can be subclassified, and then of course lipid deficiency can be subclassified. And of course, as I earlier said, meibomian gland dysfunction is the key problem, and the evaporative dry eye can be termed as the lipid deficient dry eye disease. Now, tear film deficiency conditions can be Sjogren and non-Sjogren tear deficient. It can be primary and secondary, and I'm not going into further details, but there are lacrimal diseases, lacrimal obstruction, and even reflex. If some patients using contact lenses, or if there is a palsy of the neuropalatal keratitis, there can be, of course, a reflex reason.
Can we go for conclusion, Dr. Hayat?
Yeah, I'm going. So lipid deficiency is the most important. And I'm just going to click here about there is this important cycle. And with that, I will conclude the presentation. The most important thing, we need to break the cycle which causes the dry eye. And that is the tear film instability, which is causing hyperosmolarity, which is causing apoptosis, and then lastly causing inflammation. And this cycle goes on and on and on. And there is all these etiologies that you see, from blepharitis to lid margin irregularities, drugs, allergies, contact lens wearing, environmental reasons, bacterial neurotropic, surgeries, and systemic drugs, and of course, systemic illnesses, they all contribute to this. Once we are able to contain this, and specifically, I'm talking about the meibomian gland dysfunction, I think we will be able to contain the disease. Thank you, Dr. Amri. Thank you so much, everybody. Thanks for listening.
Thank you very much, Dr. Hayat. Excellent presentation. And you actually explained everything in a very nice and good way, as usual. You are as well-known speaker and good speaker as I know you. Thank you very much. I think there is so many questions in my mind, and I think in my colleagues, and also there is a question from about attendees and participants. Is there any comment from here, dear colleagues, or question to Dr. Hayat?
Dr. Muhammad, just one comment.
Yes.
Is that Dr. Hayat, when we are dividing now, recently for the dry eye, for the aqueous deficiency and evaporation and instability. So goblet deficiency, mucin, it's one of the causes now, and we are fighting to treat the mucin deficiency. And that's why when we are saying only aqueous deficiency and evaporation, we will miss the mucin deficiency.
Absolutely.
So we need to put it as the three categories. Excellent presentation.
Yes.
Thank you very much, Dr. Safwan, Dr. Muhammad, or Dr. Sandeep. Any question to Dr. Hayat or comment?
Actually, I do have just a small comment. I want to second what Dr. Safwan just said, because to my mind, I'm pretty sure that Dr. Khan will have much more experience because he is a pediatric ophthalmologist. But to my mind, I see loads of ocular surface disease patients But in the pediatric age group, I cannot agree more that there is a big chunk of the kids that do have dry eye, and this can be missed by other doctors and can be misdiagnosed as like spring catarrh allergies or whatever. And they are given loads and loads of eye drops, and the eyes are marinated with preservatives, and which makes the disease much worse. But the thing is, in this subcategory of patients, namely the children, in my experience, I have found that only a minority of them would suffer from an MGD. These guys, these youngsters, do have a lot of mucin deficiency, as Dr. Safwan said, aqueous deficiency, yes, but for them to have a meibomian gland dysfunction, they usually escalate into recurrent chalazions, but I haven't seen an MGD in youngsters that much. So I do, my comment is leading somewhere. I do want to take the experience of Dr. Khan in this, because we do have all sorts of IPL machines now, and I have yet to use one of those. I have like 2 machines, and I have yet to use one of those on a youngster, on a child, because we do these sessions to well, old patients that do have an ocular surface disease, and we are experiencing improvement in these patients. But in these youngsters, usually, even if you do them in EDRA or meibography, you find that the meibomian glands are very, very good, especially in the graft host disease sort of patients. These patients do have a problem in their Krauss cells, in their goblet cells, but rarely in the meibomian gland sense. So again, I know that generally speaking, 70% of the OSD patients will have an MGD of some sort. My question to you, Dr. Khan, do you see this often in youngsters?
Very good question. And I completely agree, actually, with Dr. Safwan and you. So the goblet cell loss and altered mucin production, which is associated with the apoptosis due to the, should I say, the pro-inflammatory
Allograft immunogenic reaction.
Exactly.
All multifactorial for inflammation.
Yes. So I think that is most of the cases, if I may say, correctly stated, as most of these cases are not actually suffering from dry eye disease as we see most of the cases. Either they have a systemic problem, or they may have now, what happened was I was going further on that, and Dr. Amri
Sorry to interrupt you.
No, it's fine. I just concluded there.
You can now do it.
Yeah, no issues. I can go on that. So basically, the meibomian gland dysfunction is definitely, there is no comparison between how much you see in adult patients and in pediatric. You may see a lot of anterior blepharitis, yes, definitely. But meibomian gland dysfunction as such, I have not seen. But in certain cases where I have seen inflammatory conditions, rheumatoid cases, GIA cases, I have seen, these are not big in numbers. But what I'm trying to make here, sometimes these cases are missed. And we have to be careful. And the important thing is to flip the lid and to actually just have a look. And it will go a long way to know. The numbers are definitely less. So when we look at the amount of number of cases, definitely less. Adult, you see, it's like every second, third case, you will see meibomian gland dysfunction. So I would again say yes, the goblet cells are key. And as we had discussed, that we need to attend those in children. Also, initially, in the very beginning, I stated, there are now issues related to high screen time.
Yes.
That's another big issue that we are attending at the moment. And I actually took it up very quickly because of the time limitation. But I am seeing a clear change in the pattern in which kids, when they come and the symptomatology, as well as when I do clinical examination and I give some time, I'm able to elicit a lot of dry eyes. And some of them has to be just as simple as the amount of screen time and the blinking habits. The kids, they just keep on staring. They do not, and the who can tell us is the parents. So that is a problem. The magnitude has not reached to an extent as we see in adults. Definitely, I agree. And that is why I basically wanted to give a perspective more to do with kids, because these kids will become adults. And I am quite sure if we do not take the proper precautions now, 10, 20 years
Dr.
from now.
Hayat, thank you. I think we have to move because we have another question we need to cover. I have a small comment. I think using the computers and using the mobiles, at least with my experience, I can see there is a lot of children, they are suffering of dry eye more than to any other disease, even to the to the systemic disease. And this is even before the era of COVID or the effect of COVID, but it's increased now because of the COVID, because of the using more for studying. But now the new generation, everyone is 4 years, you can find a child, he is having a mobile with him and continue playing with the mobile for a long period of time, and even iPad and so on. So I think we have to take care about, those children. And in addition, I think, I didn't see any something related to meibomian gland a lot. Maybe very few cases I can see, maybe related to a certain disease or system.
But I have to say, I love the 20-minute rule.
Yeah, 20 minutes one.
The 20-second rule. That's cool.
Yeah, the 20 and they are responding very well, Muhammad. Okay. They like it. They like this phenomena. That's 20 minutes, and then 1 minute or 20 second blinking, and they are responding very well.
Nice.
But important question, Muhammad. There is in a list that the use of Zidra in children. Can Dr. Hayat Khan answer us?
Can we go before this question? Because this question, if you allow me, Safwan, okay. What is the age that you are using a cyclosporine, Dr. Hayat? If you allow me, Safwan, before that.
So cyclosporine I have been using throughout the ages, and I have not had, out of 20 years I've been using, not a single case where I found any problems using.
What is the age? What is the age? And from any age?
I use for allergies also, allergic conjunctivitis.
2 years you can give cyclosporine?
Yes, definitely, yes. I don't have a single case where I had a problem from my colleagues who are watching these cases systemically, and I feel that is pretty safe.
Okay, can you go to the second, after if you use cyclosporine for, I saw that you mentioned a lot of, a way of diagnosis, but you didn't go through if you are going to check for inflammatory. When you mentioned maybe you mentioned it as in the disease or symptoms, but I didn't see that you are doing any test for mention for the inflammations. How do you treat, the children for inflammations?
For the inflammation,
because dry eye, and you think you need to give cyclosporine. What are you depending on?
So most importantly, if we want to break the cycle, we would like to start with the very. No, I don't want to go straight out to the corticosteroids, which is I've seen quite a few of us straight away go to corticosteroids. I prefer using cyclosporin and tacrolimus. Both of these have quite well. Now, tacrolimus, you may say it's not available as eye drops. So I usually use the Protopic, which is for the skin. And I would ask the mother to just use on the tip of the finger, just half of the size of grain of rice, and close the eyes and just put it around. And that is got a good enough effect to improve the condition. So I use these before I graduate to using the steroids.
Yeah, Dr. Hayat, how do you decide to give the cyclosporine? You are depending on clinical presentations.
Inflammatory or no inflammatory, right?
Yeah, this is, yeah.
So the thing is,
You will
inflammation.
do a test. I mean, you will do that. I mean, in the old age, I mean, old patients, we can see from the history and from the examination. But in children, sometimes it's very difficult to tell.
It's
And
extremely
sometimes
difficult.
in we can use sometimes to assess. I mean, the inflammation by using. I mean, the method of testing of the inflammatory, if there or not. But I mean, the children, you know, it's sometimes it's very
Children,
difficult.
it's extremely tough. Sometimes it is extremely tough, and it's a difficult call to start. And that is another reason I'm going back to my statement that I would prefer to use cyclosporin. And depending upon my follow-up, I would like to see systemically as
So
well
you
as
are depending, I mean, in the history and examinations. So if it is
examination.
mild or moderate, you feel, and you can go ahead and give the cyclosporin.
And a lot of patients will come back. I give not a very long follow-up, maybe another 1 month. I would like to hear back how they feel, and you will see the mothers will let me know exactly what's going on with the child. But these are very small number of cases, Dr. Ramri. I'm not talking, these are, as I say, I am giving you a perspective of a very selective number of cases which are there, and they have to be identified and treated.
Yes. Okay. If you go to now the Dr. Safwan questions, Dr. Safwan is asking of using Zedra. Do you have any experience?
No, I don't have any experience. Anybody has any experience of?
Yes, Dr. Muhammad, please.
I have a negative experience with using Zedra with adults. So I think the efficacy of lifitegrast is being questioned now as we speak in these times. It has been pushed extensively by the manufacturer. It was en vogue, I think, 3-4 years ago when it came out. But then everyone is really, it's extremely expensive.
Expensive.
In this part, in my part of the world, I'm not
Muhammad,
even
in my experience, I
Everybody,
have a
expensive.
very good feedback. It's
And
apart
that's not
from the
Okay, I
expenses.
think
No,
our
Muhammad.
discussions is not the Zedra anyway,
Yeah.
but
Anyway,
it's a different
but
experience.
the Zedra in
There is
children,
some, if you allow me, there is some negative feedback about maybe the test people. I mean, in the adult. I'm not talking about the children. Now we move from the. I mean, children. I don't know. You are Dr. Safan. Do you have an experience used in a children?
no, that was my question. I don't have experience
No.
with
Okay.
children, but I have a good
Dr.
experience with
Sandeep.
adult.
Anybody else has, because I have no experience.
Sandeep.
Just one comment. In
Yes.
case you want to assess the function of goblet cell, one of the easy technique is just using impression cytology, which is very easy. You just take a blotting paper, just leave it on the conjunctiva, and then dip it immediately in alcohol and send it for lab. So it gives a very nice count of the goblet cell. So that's one comment. Zidra, I have used in adults. I didn't use in children. I have mixed feeling about it. I won't say it's negative, but I think it can be used in children. There's no contraindication to not using it because it has got the same mechanism of action like restasis. Only it has an additional step. So I don't see any reason why it should be contraindicated.
No, it's not contraindicated.
Okay, can we go now? There is another question from from participant. Which topical immunosuppressive medication you use for children other than cyclosporin?
I answered.
Yeah, just go.
Modulator, tacrolimus.
Tacrolimus. Okay. Any role of Z? Already this one I think they answered. Okay. The electronic nannies, I don't know, this mobile screen are okay, creating both physical and mental issue, and we as eye care provider need to educate all parents and about the future eye issues. Okay, I think this is a comment from one of the participants. I think we can stop here unless there is a very fast comment. We are having, no, I think we already overcome the time. If we have a time at the end of the session, then we can have a comment about the dry eye. Now we will move to our sessions and about the corneal ulcer. And before that, if you allow me, and on behalf of you and all participants and all ophthalmologists in UAE, and although you know Dr. Osama Ajladi is our dear friend, we are deeply condolence him about his father passed away last week. And also there is another our friends, Dr. Ghalib Saif, also His father passed away. In addition to our friend Dr. Safwan, also just before 2 weeks, I think, his father passed away. Deep condolences from all the ophthalmologists to you. And we hope that we can overcome of this situation of the COVID, and we get rid of this disease that make us, most of us, suffering. I think every house they are having one, have something that they are feeling sad about that. So for the corneal ulcer, the first talk, it will be by my dear friends, Dr. Sandeep. On behalf, Dr. was planned to be by Dr. Usama, but kindly Dr. Sandeep, he agreed to take this one. And he is going to have an introduction for corneal ulcer. Dr. Sandeep is an consultant ophthalmologist in Al Zahra Hospital, Dubai. He's a cornea and cataract refractive surgeon. Dr. Sandeep, the mic with you, please.
Thank you, Dr. Mohammed. Thank you for letting me speak on it, although it was a very hurried presentation. So my presentation will be very short.
Okay, can you share screen, please? Yeah. Okay, you are.
Is it okay?
Yes, please. Just if you make it, slideshow. Yes, yes, nice.
Yeah, all right. So, okay, so in corneal ulcer, what I'm going to present today is basically just the basics of corneal ulcer. What happens when you are sitting in the clinic and a patient walks in? Now, just to go back, how cornea is protected. So cornea is protected first, most important is the tear film, which has its own mechanism of cleaning its dust from the cornea. It also has the antimicrobial properties. It has got various substances which prevents the growth of bacteria in the cornea. Then we have our eyelids, eyebrows. They also protect the cornea from foreign body. And proper movement of eyelids are very important. We know that if the eyes are not closing well, you can have exposure keratopathies. And also, if your eyes are anesthetized, you can have neuropathic keratitis. Now, these are various types of corneal problems. Then the most important is the epithelium, which protects the cornea from the bacteria getting into the corneal structures, and various etiologies, like, for example, trauma, excessive use of contact lenses wherein the epithelium is bridged, can lead to corneal ulcers. The other most important reason for corneal ulcer is disturbance of immune hemostasis, and that is because of use of steroids, patients on diabetics, uncontrolled, and other systemic illnesses wherein the patient's immune status is low, can have corneal ulcers. Now, when we have a patient with corneal ulcers, the first thing with the patient presents is pain. And based on the grade of pain the patient comes to you, we actually can sort of think which type of corneal ulcer you are dealing with. So if the pain is mild, you can think the patient has either viral or fungal keratitis. If the patient is moderate, it could be a bacterial. And if it is a severe pain, it's a parasitic like acanthamoeba. The other features are reduced eyesight, light scattering, excessive tearing, discharge. Of course, there will be history of injury, contact lens wear, use of steroids. The signs are like lid edema, there's hyperemia of conjunctiva, edema of conjunctiva, epithelial infiltrate, stromal necrosis, thick hypopyon, which can be mobile or immobile, and there can be endothelial plaques, endothelial cells, and sometimes stromal edema and Desmond folds. It depends how deep the corneal ulcer is involved. So when you see keratitis, it's very important to differentiate between an infective keratitis and a non-infective keratitis, because that actually is the basis of treatment. So If it is a non-infective, the treatment is different. You treat them with steroids. If it is infective, the treatment is with antimicrobial treatment. So the diagnostic tool, most important, of course, is the slit lamp examination. If you can take a picture, it's even good. A simple fluorescein test on the cornea, which give you a lot of clue about the type of corneal ulcer. Of course, if you have a rose Bengal stain or a Leishman stain, is good for diagnosing viral keratitis and fungal ulcers. Then comes corneal scraping. It's must. If you have a lab, it's better to do a corneal scraping in all cases of corneal ulcers. Corneal biopsy, if your corneal scraping does not fetch good result. Sometimes if the ulcer is very deep, you can use a suture to collect the sample. Nowadays, we have a PCR test, which is for viral keratopathies, and of course, confocal microscopy if it's available. And it's also important to look for systemic etiologies, for example, tuberculosis. So if you have a corneal ulcer non-responding, so you must get a tubercular workup done, especially for patients coming from Asian background, gold quantiferin test, of course, blood sugar. Many patients actually don't know that they have silent diabetes. And it's important that any corneal ulcer patient, you must get a blood sugar and HbA1c done. Look at for the immune markers, like for example, rheumatoid factor, antinuclear antibody, ANCA, etc. Now, coming to corneal scraping, which is the basis of diagnosis of corneal ulcer, is very important how you do a corneal scraping. So a corneal scraping should be done to take enough material from the base and the margin of the corneal ulcer. And it's important that a good corneal scraping should have enough epithelial cells. If your corneal scraping does not have epithelial cells, that means your corneal scraping is not adequate. You go ahead and repeat it again. I prefer to do it on slit lamp, but you can use a microscope you have available. You can do a gram stain if you are doing it yourself, it is better, or you send it to the lab. You do a KOH mount for a fungus and a Ginsa stain, especially to look for the cytology. You can also do a PAS stain for both for fungus and bacteria. Regarding the corneal scraping, you normally use a blunt blade. You ideally not use a sharp blade because you can perforate, because some of the corneal ulcers are thin corneas. If you have a Kimura spatula, use that. And how you plate once you take the sample from the cornea is also important, because you should not break the medium, the culture medium on the plate. So you should plate it like a C, and how you transport these media back to the lab is also very important, because if you don't transport it properly, you might not be able to get good culture results. These are the common things like blood agar, chocolate agar, high glycolate broth, brain heart infusion broth if you're looking for anaerobic organisms, subrose, dextrose agar, and of course, if you're looking for acanthamoeba, you need to have a non-nutrient agar with E. coli. So these are the common things which should be available in your outpatient, or you can get it from your lab when you have a patient with corneal ulcer. Now, sometimes the ulcer is very deep and you may not get the organism by scraping. So in that case, you use a 3 millimeter or 2 millimeter skin punch, and you can take a corneal biopsy, and then you can send the material to your lab for both for histopathology, cytology, and organism. And especially, it's important for deeper infections like fungal and acanthamoeba. Also, this is important to look where the ulcer is located. For example, in this case, you can see the ulcer is a marginal ulcer, and you look at the lids, have a blepharitis, you know probably it's a staphylococcal in origin. Whereas if you see an ulcer which is more central and more suppurative, you think that it could be a streptococcal organism. So the location of the ulcer also gives you the type of diagnosis you are looking at, the organism you are looking at. The role of cytology is also important. If you see a lot of polymorphonuclear cells, you're probably dealing with a bacterial infection. If you see more of mononuclear cells, you're probably dealing with a fungal infection. So it's also important to look for cytology, and that's why HND stain or a PAS stain is important. Sometimes you need to do special staining For example, a Z lesion stain, if you look for a typical mycobacterium, which is very common in post-LASIK patients, or you have to use a patient with a corneal transplant. Sometimes they have unusual infections which don't respond to treatment. In that case, you have to have special stains. Coming to one of the other important keratitis is herpetic keratitis, which of course most of the time clinical presentation is very important. And one of the dye which we use is the rose Bengal stain. It gives a very nice staining of the dead epithelium, and you can typically see the dendritic pattern of the herpetic infection. Of course, if you have a doubt, you can do a PCR test in some of these patients, and they can be negative or positive, but it helps in diagnosis. But even before doing any test, the most important thing in corneal ulcer, if you're thinking of viral keratitis, is checking the other eye and this eye and check for the corneal sensation and compare. If you have a patient with reduced corneal sensation, you can pick up herpetic keratitis in these patients. So it's very important that you check for corneal sensations even before you put anything in the eye, even fluorescein. Another infection which is sometimes missed is acanthamoeba keratitis, which sometimes mimics like herpetic keratitis. The patient presents, it may not be very classical ring ulcers, but patient does present with severe pain, which is out of proportion to the signs. And in this case, you can see a ring infiltrate with very little surface involvement. Sometimes they have neural presentations, what is called as neuritis, perineuritis. And the problem is acanthamoeba sometimes gets diagnosed very late. By the time the ulcer progresses deep into the stroma, it's very difficult to treat them. So the role of confocal microscopy is important in these cases. If it's available, you can pick up the cyst in vivo, and you can also see the infiltrate tophozoids which are migrating into the nerves, corneal nerves, but it may not be available for each and every all of us. Coming to the treatment strategy for any corneal infection is either you can do a monotherapy, which is a broad spectrum antibiotic, or you can prepare fortified drops. And I have this chart which is called Bug Buster, which has actually been prepared by the doctors in LV Prasad Hospital in Hyderabad, because we have lots of infections in India. So it's very useful. If anybody wants it, I can just pass it on. It tells you how to prepare topical antibiotics, antifungals, antiprotozoan for subconjunctival use, intravitreal use, intrastromal use, and intravenous use. So it's very important for us not only to prepare the drops in a sterile atmosphere, it's also important how you dispense them to the patient. So you must tell them, look, how you should maintain a proper temperature in which these medicines should be kept, how frequently you should replace them once you take them from the hospital. And once the infection is controlled, you also need to know what are the other supportive treatment which the cornea needs. For example, if the cornea is responding and getting thin, you know the cornea can perforate any time. So you must give vitamins, you must give tear substitutes, you might have to use amniotic membrane, and sometimes the ulcers don't respond. So you have to move from to other treatment like CXL, for example, or tarsorrhaphy or amniotic membrane. And the worst scenario, you might have to do a keratoplasty where the results may be variable. In some, and probably deep lamellar in some cases can also be very helpful. So just come to summarize, the corneal ulcer is a big topic. I mean, to give you an introduction is like a bridge. You don't see the other end of it. So it's a huge topic. But just to summarize, so when you have a patient in your clinic and you're looking in a corneal ulcer, there are a few golden rules. The most important is before you start antibiotic, try to get a sample. Just don't blast the patient with multiple antibiotics. That's one. Number two, look into the symptoms and signs. That gives you the clue what type of ulcer you're dealing with. And sometimes the ulcers don't respond. Then you have to think laterally and think of unusual organisms like nocardia or mycobacterium, or sometimes even sporadic infections, which are very uncommon. So, so that's the introduction. I stop here, and it's open to questions to others.
Thank you very much, Sandeep. Very nice introduction for our topics. It's an excellent. You cover most of the things that we need to hear from you. Excellent. If there is any question, I think it's better. What do you think, Safwan and Dr. Muhammad? Others, we can keep to the end, or we can. You have one question, two questions in the beginning.
I think that one few comments we can go through.
Okay, very fast. A comment if
Very
that
fast.
there is. Okay, because you have 2 minutes for this presentation. Go ahead.
So Sandeep, excellent, quick presentation for, as you said. One comment, as you said, no antibiotic before sample, and sometimes debridement and epithelial debridement carry a very good chance for healing, especially when we have viral or acanthamoeba. That's important comment we need to add it. And as you said, differentiation in sensation and pain is crucial sometimes when we are dealing with the viral or acanthamoeba. Thank you.
Okay. Dr. Muhammad?
I do not have any comments. It was a very, very nice, comprehensive introduction. Dr. Mitra, thank you very much. I personally benefited a lot from it. Thank you.
I think Dr. Nancy, she joined us already now. If she is there and if she have any comment, welcome, Dr. Nancy.
Thank you very much, and excuse me for being late. I have just one comment. Maybe I wanted to mention it because a lot of shared information with my presentation regarding the sampling. What I do in my practice is that even if we started the patient antibiotics and I see that there's no improvement, I still take a sample without stopping an antibiotic because, and I've been doing this recently because if the antibiotics or the treatment has been doing a good job, then it wouldn't have caused a deterioration in the case. So I don't stop any antibiotic and I just take samples, especially if it's something that's not covered, like mostly it's the acanthamoeba or a fungus that shows even if I did not stop any antibiotic treatment. So this is how I've been doing it.
I think this point it needs more discussions. Maybe I think we can have this discussion at the end of your talks.
Yeah,
maybe. Okay, so we can move to the next talk, and it will be by my dear friends, Dr. Muhammad Husni. Dr. Muhammad Husni is a professor of ophthalmology in Cairo University, and he's a cataract, cornea, and refractive surgeon, and he is a well-known figure in ophthalmology in our area and in the world. I'd like to thank him for being with us, and he is going to talk about the bacterial and corneal ulcer from the bacterial point of view. Winning the battle against the bacterial. Let us see if Dr. Muhammad is going to win or not.
He's always winner.
We will see at the end, Safwan. Why you are anticipating the
always winner? It's a very loosely to say that he will not.
He's just boosting my morale as always. Can you see my screen?
Yes.
And you can see only the presentation, right? Not the presenter's view, right?
It's a presenter view.
Yes. No.
It's in the presenter's view?
No. You are not. No, you are. We are not seeing you.
Presenter view.
Presenter view. Okay, so that's a glitch. So I don't know how to get out of this.
You can
go to the slideshow.
Exit. The 3 dots.
The 3 dots. More. Yeah.
Yeah, the 3 dots, and then you exit.
Here, the 3 dots.
Sorry? Come again?
3 dot down.
3 dot below the screen.
Yes.
Okay, John, can you help Dr. Muhammad, please?
You can even have it at the top. You have end slideshow.
End slideshow on the top.
No. Either of the two.
Just a sec. Nope.
Wayne, can you stop from your side, please?
No. I think I have to.
He will stop. Yeah, he will stop. Now we can share again. This is the best way. So for a fast.
Okay. So just a second. Yeah. It's again presenter's view, right?
No, perfect. This is the
Now
one.
it's good. Now you are okay.
Yeah,
No?
it's okay.
Now it's okay.
Yeah, you are okay now.
Yes, okay.
Okay. So now you can see the screen.
Yes. Can
Yes.
all the speaker mute themselves, please, and give the mic for Dr. Mohammed. Please go ahead.
Okay. So good afternoon, everyone. Assalamu alaikum. It is an honor and a pleasure to participate in this presentation today with you guys in this MEOM meeting. So thank you for including me among this panel of heavyweights. I really enjoy the company, even the virtual company of Dr. Safwan, Dr. Amri, Dr. Sandeep Mitra. I enjoyed very much the talk of Dr. Khan today, and of course, welcome my dear friend, Dr. Nancy. I will be speaking today about the bacterial corneal ulcers. Now, when we talk about corneal ulcers in general, it's usually the comprehensive talk like the one that Dr. Mitra just gave. The aim, and I anticipated this. I didn't know that he was going to do this. I thought that Osama Al-Gladi will be doing exactly the same. So what I tried to do is to beat around the bush a little bit and not give a classic sort of comprehensive review on bacterial corneal ulcers, but rather than to give pearls in each and every aspect of the bacterial corneal ulcer. I imagine that the basic knowledge is always in the textbooks, but when we do a ward round, when we see patients with our junior colleagues, we open up our ears for the experiences of each other, and the tips are the ones are the things that make your life much easier. I tried as much as possible to bring a lot of tips in this presentation and to keep it within the range of 15 minutes, because Dr. Amri is a tough judge. So that's what I will try to do. I'll try to be as brisk as possible. From where I come from, we see a lot of corneal ulcers, and we see a lot of corneal abscesses, and we see a lot of infective keratitis in general. In Cairo University, we see loads and loads of them. And whenever we have a casualty day, which is for each department once a week, it's like loads of patients. I'm pretty sure that this is the case, like Dr. Sandeep said, in India, but I'm not very sure that this is the place in somewhere where you have, the general population much more cultured and with a higher, living standard like Dubai. But again, we do see a lot of corneal ulcers. I would presume that our residents at Cairo University are the world experts in corneal ulcers, infective keratitis. In developed countries, this is usually related to contact lenses. Back in the day when I used to practice in the UK, most of the patients that had infiltrates in the cornea used to have a contact lens involved in the story. But in agricultural communities like Egypt, it can be related to corneal injury with plant objects, and this can lead to a fungal or a bacterial. In an exam, you would say a fungal, but more often than not, we see bacterial keratitis from a plant injury. So in underdeveloped countries, you can have an abundance of both factors, and this is the thing that we see. We see people that are not very cultured, are not very educated, that would leave a contact lens, girls that we see would leave a colored contact lens in her eye, a disposable colored contact lens in her eye for a month without changing it. And we can see peasants and people from rural areas having eye trauma and corneal trauma from plants and agriculture. Many organisms can be isolated from the lesion, bacterial, fungal, protozoal, but at Cairo University, we see a lot. And the most common organisms that we see frequently are Pseudomonas, Staph aureus, and Fusarium. I think the pearls in management make all the difference. And I have subdivided the tips that I'm going to address into 4 categories. Identifying the organism, starting the treatment, what treatment to start with, The steroid dilemma, which is a debate that's going on and has been going on since I was a resident back in the day in '94. And the follow-up mistakes. You start treating the patient, and then some inexperienced doctors would have some hiccups along the way after properly treating the patient. So let's take it step by step. Identifying the organism. I do agree. This has been said by Dr. Nancy, this has been said by Dr. Safwan Bayati, and this has been said by Dr. Sandeep Mitra, and I totally agree. Instruct the staff, and by the staff I mean the nurses and the paramedics, that when they are the frontliners, they will see the patient before you see them, and they have to identify symptoms of corneal ulcer. And if they do that, then no eye drops, no anesthetic eye drops, no dilating eye drops, nothing whatsoever. I want to see the patient as he is. If you're doing a corneal scrape, Dr. Sandeep Mitra said this, and I only have to confirm this, that you have to include the base and the edges of the ulcer. You have to include some epithelial cells, because these are the epithelial cells that are loaded with the organism, and the fellow epithelial cells that were loaded with the organism the day before, they sloughed and caused the ulcer. So these will tell you what happened the day before. So it's extremely important to take a good scrape from the base and from the edge of the corneal ulcer. Again, it's not a bad idea to include the conjunctiva and the conjunctival cul-de-sac with even a Q-tip, and then spread it on the top of your culture medium. What I do, and what I always instruct my junior colleagues, my trainees to do, is that we use split plates. We use duplicates of everything. I use blood agar 2 plates and chocolate agar 2 plates, and I incubate one of them in the incubator and leave the other one in room temperature, because it's very common in my part of the world that we have a fungal infection. Fungal infection would definitely grow much, much faster in the room temperature plate rather than the incubating the plate in the incubator. You can incubate the plate in an anaerobic incubator if you suspect an anaerobe. But again, I come from a place where we see a lot of corneal infections, and it's extremely rare to see anaerobic infection in the cornea. That's it. Do not confuse yourself. In starting dealing with the scraping, do not put a lot of culture media, do not use thioglycate, do not do a lot of things. Just blood agar, chocolate agar, 2 plates, 1 plate goes to the incubator, the other one stays in room temperature, and that's it. And wait and see. And usually you'll get what you're looking for. Primary clues in identifying the organism. When you see the patient in the outpatient clinic, just take a look at the cornea and take a good deep breath and observe the cornea. One of the very important things that can give you a clue is that if you have an endothelial plaque, sometimes it is difficult to see for 2 reasons, because sometimes the plaque itself is very faint, and sometimes the cornea is not that much transparent, so you will not be seeing the backside of the cornea. The edema and the infiltrations will be in the way, so you will not see the endothelial plaques. But look for them. Look for endothelial plaques. There will be a lot of things going on the surface of the cornea, the ulcer, the dimensions of the ulcer, whether it is an advancing ulcer or a healing ulcer. How do the edges look like? What does the base look like? Leave all this and try to go around the ulcer and take a look at the endothelium. If you can identify even a faint endothelial plaque, then most probably this infection is fungal or has a fungal component. This is a very important thing. Gram-positive ulcers, they are usually not mushy. These are very solid ulcers, and the base is very regular, even if it is heavily infiltrated. It has, like, if you swipe it with a Q-tip, it has like a sandy appearance, and the cornea looks, the integrity of the cornea looks much better than gram-negative infections, where you have a lot of melting going on, and when you're removing things with your Q-tip, you don't know if you're removing actually discharge or corneal molten tissue. So this is something that you have to teach your younger colleagues, that if everything seems very solid, then if it is bacterial, most probably it's gram positive. If everything seems very mushy and on the process of melting, then most probably this is a gram negative. Then look for the endothelium, see if you have plaques or not, because this will direct you to the fungal etiology. Ask for the history of herpes and know that in these patients, if they have a recurrent history of herpes keratitis, the patient can come back with all sorts of forms. It doesn't have to be a dendritic ulcer. The herpes keratitis can recur in any form, in any of any sort. So you have to test for the corneal sensation, but do not confuse a herpetic ulcer with a decreased corneal sensation with a neurotrophic ulcer, because these are two different kinds of fish. The first one, you will definitely need to do an antiviral, to give a heavy antiviral treatment and an antimicrobial umbrella as well. And the other one, you need to lubricate, and not to bombard the cornea and the epithelium of the cornea with too much antibiotics, especially that in these situations, in the infectious keratitis, we love preservatives, and we love heavy eye drops that are not very cornea friendly. They will kill the organisms, but they will definitely affect the ocular surface. So we use them only temporary until we're sure that the organism has been killed, but we do like benzalkonium chloride, we do like preservatives. So this is something that you have to keep in mind in your initial diagnosis. If the patient has a neurotrophic keratitis, then definitely this is not the way to go, and use as much as possible lubrication and avoid preservatives in your eye drops. Okay, so you have diagnosed the patient, you have done your scrapings, and the lab tells you what to do, or is going to tell you what to do. The common consensus all over the world is to start the gunshot treatment before converting to the bullet treatment. When you get the results from the lab, you start your treatment immediately. Okay, start your treatment immediately. Everyone all over the world, this is just common knowledge, uses a fluoroquinolone now. So the thing is, just ask the patient if he's been seen by another ophthalmologist and he's been on a fluoroquinolone for quite some time or not. Then you have to change the regimen that he's taking. But if he's not taking a fluoroquinolone, if he's been diagnosed with something else, and you see a lot of patients that have been diagnosed with like an allergy and has been given steroids in a primary healthcare center and comes with a corneal ulcer, an infective corneal ulcer, because of the use of steroids, then start your fluoroquinolone. If you have besifloxacin, which is not available in my country, we do have it imported, but it's not commonly available, use it. Besifloxacin is the drug of choice. Always choose the eye drops with preservative, because a lot of doctors do have this feeling that the preservative-free eye drops are like a higher quality eye drops than the eye drops that we put a lot of preservatives in. So you like this patient and you're very keen on him getting better, so you give him the high quality preservative-free antibiotics, which is the wrong way to go. We love benzalkonium chloride, and it's the best. Benzalkonium chloride only without any antibiotic is extremely effective against methicillin-resistant Staph aureus. So we want the antibiotic to be with the preservative. Gentamicin, good old gentamicin, is extremely effective. Amikacin eye drops are extremely effective in the sense that they are both antibacterial and antifungal. I start off with amikacin eye drops, and they're extremely easy to formulate. You just get an ampoule of amikane, 500 milligrams, and put it as it is on the eye drops, any lubricating eye drops, and let the patient start. I always use betadine or povidone iodine, and I find it extremely helpful in bacterial keratitis. Try as much as you can to avoid autologous serum. This is a fancy sort of treatment that has to be reserved in very clean conditions, and it's very common to have autologous serum, give it to the patient. In 48 hours, it becomes infected as well. So the patient puts the organism actually himself into his eye. So try as much as possible to avoid autologous serum in acute infective corneal ulcer, and lubricate. Okay. The steroid dilemma. This has been an ongoing debate since like more than 20 years. Classically, we've been taught that no steroids with a corneal ulcer, or else you can get melting of the cornea, you can get exacerbation of the bacterial proliferation. And this is actually true. Going back to the basics, we just want, you know, as one reads more, you want to get the more updated. So at one time, at one point, the Scott study came out and was published in the archives. We all loved it. And we started, you know, questioning the basics. Why should we not use steroids? Because the Scott study said, Scott study is the steroid and corneal ulcer trial that has been published, I think, back in the day in 2010. And it showed that the best corrected visual acuity in these patients that you use steroids in and the ones that you did not use steroids in was pretty much the same 3 months out. And the rate of re-epithelialization did not differ. But this is in their countries. From where I come from, we do not use steroids. Why? Because it's very common in Egypt, at least, that we have mixed infections. So fungal keratitis and steroids are a bad combination. They will flare up very, very, very aggressively. Pseudomonas is very common in Egypt as well. And we know that Pseudomonas has a sort of sclerokeratitis where more and more melting of the collagen happens because of the proteases that the Pseudomonas itself secretes. And it excites very much the cells of the cornea and the sclera to secrete metalloproteinases. So melting happens in no time. Do not use steroids in these patients as well. And if you have a herpes, it will flare up. So if there's always a possibility that there's a fungal component, there's a Pseudomonas component or a herpetic component, so no steroids in my opinion. The follow-up mistakes. Never confuse infiltration with ulceration. This is a very important point. Now, you see a patient, you start your treatment, and your treatment is good. And then after 2-3 days, he comes back and you take a look at them and the infiltration becomes more dense. And the intuition of the young doctor would be that the patient is getting worse. This is not true. Always look at the dimensions of the ulcer and try, if you cannot photograph the ulcer, then try to draw the ulcer, because it is very common that the edges of the ulcer start to heal and the ulcer becomes more and more small and the infiltration becomes more and more consolidated and dense. And there's nothing wrong with this. This patient is getting better and better. Now, the other things that you should look for is a loss of pain and loss of angriness in the eye and loss of conjunctival congestion. But mind you, a lot of the eye drops that we put, especially fortified eye drops and especially povidone iodine, would lead to injection of the eye and congestion of the eye and edema of the eyelids while the patient is getting better, not getting any worse. Okay. Pseudomonas corneal ulcers and abscesses, we see them all the time. It is, and the thing is, in this specific type of ulcers, melting is very, very common. So you have to manage fast, and you have to avoid melting fast. Okay, so these are ulcers that are rapidly progressing, and these are conditions that you really have to man up and give the treatment aggressively. We see Pseudomonas all the time. And there are new weapons that we are using in bacterial ulcers nowadays in the university hospital, and they are actually doing very, very well. One of them is the PAC-CXL, or the cross-linking, which at one point was actually contraindicated in corneal infections and corneal ulcers. Now I've been enrolled in a worldwide study, in the Swiss PAC-CXL study, and the results that we made in Egypt and we contributed to this study were simply amazing. And again, the hot femtosecond penetrating keratoplasty, which revived the keratoplasty I showed that we used to do with the trephines. So just in a nutshell, what does PAC-CXL do in bacterial corneal ulcers? Firstly, the planar ring structure of the chromophore inserts itself between the bases of the DNA and RNA. So the vitamin B12 itself inhibits the organism, inhibits the bacteria. The other thing is the release of oxygen kills the bacteria, which happens during the cross-linking process. The last thing is that the cross-linking of the remaining collagen of the cornea, the remaining healthy collagen of the cornea, makes the cornea much more stiff and much more resistant to enzymatic degradation and melting. There are different protocols, but mostly what people use is the Dresden good old protocols. There are studies that have reported the results of accelerated protocols, but there are other studies that are using more time and more energy in the cross-linking in this specific type of patients with success. A lot of patients are using what we call the window absorption technique, which is basically that you do not remove the epithelium from the rest of the cornea. You just instill the riboflavin on the cornea. This is not an epi-on cross-linking. This is an epi-off, but you only insert the riboflavin into the stroma of the cornea at the site of the ulcer, and that's it. You do the cross-linking and you get good results. We have had good results, and these are real pictures of my patients, okay? And the patients responded very favorably with cross-linking. The last thing that I'm going to speak about, again, in just a minute or two, is the assisted femtosecond laser assisted PK. We have all known that we can do keratoplasty à chaud or hot keratoplasty, but we always had the fear, which is justified, that during trephination in this thin cornea, if you have an impending decimal seal or something, that you can have a perforation. And this is something that could happen. And this is something that prevented us from taking the decision to do keratoplasty in these patients. But with the advancement of the femtosecond laser, we've been doing femtosecond laser PKs since 2012. And we have actually published our results in femtosecond laser assisted PK as show in cornea, in the journal Cornea. And we have presented it in the ASCRS in 2014. And definitely with the docking mechanism, we actually close the ulcer and the impending decimal seal if you have, and then you have, and the pressure that you're applying on the eye is much less than the manual trephination, and you get much better results, especially that with the complex architecture of the wounds, you put less suture, so the eye becomes less angry post-operatively. We have reported many cases in this, and again, this was a publication in Cornea, I think in 2019, and we presented this in the ASCRS in 2015. This is just a very short video of the technique. I will run it through. This was a case of a pseudomonas corneal ulcer that has been definitely diagnosed and been very resistant to our antimicrobial treatment. We did the docking the good old way, no worries whatsoever, no rupture happened. And this was the very first case that encouraged us to do this series of patients. And unlike the MUT study of the fungal corneal infection study, we found the results very good and not controversial at all. Actually, these patients after the surgery were very quiet eyes with very good vision. I'm just running through this video, and we had very good results. These are just a sample of our patients that we did penetrating keratoplasty using the femtosecond laser in a pseudomonas or a mixed infection corneal ulcer. In conclusion, I think that PAC-CXL is proving to be effective both as a monotherapy and an adjunct therapy for bacterial keratitis. Different protocols are proposed by different study groups. All have shown success. Standardization of the technique is yet to come, and in the looming danger of increased antibiotic resistance and the absence of new antimicrobial molecules, no new antibiotics are coming out. So the real danger facing the planet is global warming and antibiotic resistance. So in this situation, I think PAC-CXL does have a role. The other thing is that we can definitely use penetrating keratoplasty if you do have a femtosecond machine, which makes the surgery a little bit more safe in this subcategory of patients. We should not give up on these patients. If they are melting, you just lose hope and keep them on the antibiotics until we have all sorts of fibrosis and synechia in their anterior chamber. And I think that's it. And thank you so much for letting me share this presentation.
Thank you very much, Dr. Muhammad, for an excellent, comprehensive presentation. It's a good journey. You take us in all the corneal ulcer related to bacterial infection and the new management by using cross-linking. And this, maybe we can have a question and discussion. I do prefer, if you allow me, we can go because we are running at time. So we can have a good discussion, but let us be in the end of all presentation, if that's okay with all. It's okay. We can go ahead. I will now introduce the next presenters. It will be Dr. Nancy Al-Raqad. She's a FRCS Glasgow consultant cornea, cataract and refractive surgeon in Royal Medical Service in Jordan. Dr. Nancy, she will share with us her experience also and the management in corneal ulcer with acanthamoeba. Dr. Nancy, please.
Thank you very much for the introduction and the invitation. And I'm very thrilled to be part of this group. Allow me to share my screen. Can you see my screen now?
Yes, go ahead. Yeah, okay.
Okay, so I'll be talking about acanthamoeba ulcer or acanthamoeba keratitis, which is a very important topic. We're seeing more of contact lens wearers. We're seeing more than has been reported about the prevalence of acanthamoeba. Simply put, acanthamoeba is sight-threatening, and we all know this, and it carries a poor prognosis due to significant delay in the diagnosis, and it appears to be multifactorial, but mostly we see it in contact lens wearers and the solutions of the contact lens related. Now, reported to be 1 to 9 in 100,000, but actually we're seeing more numbers than this, as Dr. Husni said. Acanthamoeba thrives in soil and aquatic environment, that pools, swimming pools, hot tubs, and contact lens solution. Because I see sometimes patients, they just warm the solution, thinking that this makes it sterile. Actually, warming it up gives a good medium for the acanthamoeba or the parasite to grow. The most common species that we're seeing of the acanthamoeba are the castellani and the polyphagia. And I want to speak basics because this is very important for the junior doctors that are watching us. And we all know that exists in two forms, the cyst and the trophozoite. Now, it's the problem with the cyst that's resistant to the hostile environment. Any change in temperature, the pH, high dose of UV light, food deprivation, desiccation, it is resistance. It is a strong microorganism. Now, why is acanthamoeba challenging? It's challenging in diagnosis because most probably we diagnose acanthamoeba very late. And usually contact lens wearers typically seek medical help late because they're used to the minor irritation of their eyes. And it can easily, in the earlier stages, it can easily be confused with herpes simplex keratitis, especially in the epitheliopathy stage. Now, in the advanced stage, it looks like a fungal ring or a very advanced bacterial keratitis. So this causes a dilemma. And there's also a challenge in the treatment, especially the treatment of the cyst. And there's also a challenge in managing the sequelae. We have to know that even one cyst after a year, whether in a stroma or in the angle or in the cornea, that can cause a reinfection. So monitoring is crucial for months. How does it present? Now, acanthamoeba keratitis should be considered in all contact lens wearers. Now, any case of corneal trauma with exposure or soil or contaminated water, even if there's no contact lens history, also should be suspected. Common symptoms, we all know about it. It's the massive pain, which is out of proportion for the clinical picture, the photophobia, the tearing. Now, this is a very important bit of information. The sooner you diagnose the disease, the better is the outcome. So suspect it, think of it, and look around for anything that proves it is acanthamoeba. Whether it is an epitheliopathy, a history, a pain that is unrelenting, because if you delay the diagnosis, the amoeba will cut through the stroma and then penetrate so deep, and it will be very difficult to incubate and culture. So the diagnosis will be also delayed and also very difficult to eradicate. It's usually unilateral, as we know, and it has 5 levels of presentation. Now, In the early stages, it comes as epitheliitis, only in the epithelium, epitheliopathy. A very important pathognomonic mark is the radial neuritis. I tried, this is a photo of one of my patients that has been going on around for weeks. Tried a lot of drops. And when I saw her, I just was looking for something that proves this is acanthamoeba, and I saw 3 radial perineuritis or keratoneuritis, and they were inflamed and engorged and just sticking there that nobody noticed. So this is a very important sign to notice any patient suspected with with acanthamoeba. We have the anterior stromal disease if it cuts through into the stroma, the deep stromal keratitis, and then the ring infiltrate, which is you can only see in 50% of patients. So it's more important to look for a radial perineuritis rather than a ring infiltrate because it can be mixed with a pseudomonas, a Wesley ring, an immune reaction. Anything can come. It's not only pathognomonic for acanthamoeba. What about diagnosis? Now, the most important step in diagnosis of acanthamoeba is thinking about it. And I want to highlight that although we don't typically take specimens now if we suspect and we start treatment right away, if I see pathognomonic signs, depending on the clinical picture, but I always encourage the juniors to just scrape it and take a culture. And it's very important to take the culture properly, because if you don't take a culture that properly, then you cannot justify the long time of treatment. And also you cannot justify the expensive drops, and you cannot justify the whatever sequelae, because it has a very poor prognosis. 50% of patients ending up with a corneal transplantation. So the right way of taking a sample is that you have to prove it by culture, a specimen, or on a smear or a culture plate. And how to take it? We have to be as deep as possible, because the amoeba usually cuts through into the stroma. If you just take a swab or a specimen from the epithelium, it will not give you any result, and it will come back as negative. And this will confuse you more and delay the treatment more. So there's also another way of, if you want to make a quick diagnosis, is the staining. There are lots of stains, almost 11 types of stains that we can stain the amoeba, especially the cyst, because it takes the stain and autofluoresces. There's the calcoflower white, the PAS, the silver, iodine. A lot of stains can be used to check for the cyst, but it's important, as I said, to take a deeper. If you see an ulcer, an infiltrate, you can take it deep. Sometimes go into the stroma. Just don't reside for a shave of the epithelium. Now, how to take a sampling? We said, especially in advanced disease, go deep, and the material has to be put in at least 0.2 cc of fluid, because if it gets dry or desiccated, then this will interfere with the result. It's very important to take the biopsy in a 0.2 ml of saline. Okay, now you can also take the contact lens solution if it's not changed, because mostly 99% it will be positive for acanthamoeba. If you culture the solution at the contact lens and it comes back negative, it's unlikely that this is an acanthamoeba. Okay, the most likely thing that you haven't taken a good specimen, unless, of course, it was freshly changed. Now, these are photos of my patients, and we've been seeing a lot through the past few years. So the first one is, you can see this is the corneal edema, an epitheliopathy, some cases that resembles herpetic keratitis. Now, it's needless to say that acanthamoeba does come associated with other microbes, especially herpetic keratitis. It comes in the percentage of 30 to 33% associating and complicating acanthamoeba keratitis. So I wouldn't be surprised if I see corneal edema or stromal edema. The epitheliopathy is striking. It does not look like epitheliopathy, the epithelial dendrites, which are typical for herpetic keratitis. Once you start the treatment, the other photo shows starting to organize. The edema is not there. As you can see, it's just organizing into an infiltrate. One of the very important things or tips I want to mention is the vascularization. Now, vascularization is something you don't want to see in the cornea, except if there's an infection. The reason for that is that if the blood vessels, they target an ulcer, this means that you're going to resolve quickly, although it might leave a sequelae of blood vessels. Now, what we do in a cornea with a limbal stem cell deficiency, or a cornea that has a chemical burn or whatever to the blood vessels, we try to cauterize, we try to remove them, we try to give anti-VEGF treatment to remove them. But if in infective keratitis, this is something I want to see. And this means that the cornea will heal and the infection will subside. So I do not touch these vessels. I let them do the job. And once the infection has subsided, then I would interfere. And if they're still there, and I guarantee you they will reside once the infection and the limbus is okay and the cornea is okay, they will just be pushed back. And this is the same patient with the last photo, as you can see, where we performed penetrating keratoplasty. That's months later for the cataract and the scar that has been left by the acanthamoeba. So as you can see, there are no blood vessels around. Now, how to treat? As we said, first think of it. I remember one of my best patients and my friends. He's an oncologist who came to my clinic after being in Morpheus, and he had a contact lens for recurrent corneal erosion. He left the plane and came back to Amman instead of going to Baghdad to see me on a night of operating day. And he was in severe pain. I could not see anything except just epitheliopathy. And I told him, I think this is acanthamoeba. And unfortunately, we don't have, except chlorhexidine that I can fashion manually. We don't have the chlorhexidine proper for the eye. I just use a mouthwash, and this will burn the cornea. So I would rather, and this was his only seeing eye. So this was a very difficult situation. And he had like so many connections, and we could retrieve the proper PHMB and Brolin from London a few hours later, and start him immediately. So because there was an immediate, without scraping, without anything, because there was an immediate start of therapy, he resolved, and it started to resolve like in a few days. The fifth day, 70% is gone, and it left only a very, very minimal scar. Now he's the major importer of anti-acanthamoeba drops to all my patients in Jordan. And he always reminds me that when you saw me, you said, although acanthamoeba is very bad, but you said to me, I never lost an eye for acanthamoeba. And I always say, Alhamdulillah. And I hang to this when I talk to my patients about how bad it could be of an infection. Now, we take specimens, but we don't wait for it because it can take a long time. Start therapy. Even if you don't have any anti-acanthamoeba treatment, any antibiotic would kill the trophozoite. So as Dr. Mohammed Hosni said previously, fluoroquinolone, start with any antibiotic. The trophozoite at least would be killed if you suspect this is acanthamoeba, but does not kill the cyst until you figure out where you're standing. If you have a proper anti-acanthamoeba treatment, I'll mention the protocol in the next slide. Start it. Steroids is a big debate. I use it for some of my patients, although it's a big contraindication sometimes. I do use it when I feel I need to, with caution, of course. Cross-linking, as Dr. Mohammed Hosni has just covered that beautifully, proved efficient, but not in many cases of acanthamoeba. Let's remember that acanthamoeba resides very deep in the cornea. So if you want to use cross-linking, unlikely to reach that unless you use the sub 400 protocol to go deep. And then the follow-up is an issue. It's a long-term relationship between the doctor and the patient. And I will talk about keratoplasty in just a few seconds. Now, what's the protocol? I follow the Joan Dart protocol. I will admit the patient if I needed to. If there's a big infiltrate, I start bombarding him with polyhexamethylene biguanide, which is an antiseptic, and Brolin hourly, day and night for 48 hours. And then I go the third day for 2 hourly, because PHMB is toxic. Brolin is also toxic to the cornea. I try as much as possible to bombard it the first few days and then just to taper it along. Remove anything else, the cornea will look very bad and very sensitive. So we'll try to use as much as possible preservative-free drops. If you're using artificial tears to be for comfort, try not to use dilating drops. and try to keep it as minimal as possible so you know where you're standing. If there's a herpetic infection complicating the story, I prefer to give oral rather than a topical to decrease this toxicity on the cornea. Now, I taper it until I reach 3 to 4 weeks, 4 times daily, and then I keep it for months. As we said, even one cyst can reinfect. Do not go to steroids. Never think of it unless you see there's an anterior segment reaction, an AC reaction, anterior synechia. Sometimes you see it. Scleritis is very rare, but immunocompromised patients, you can see this. You can have a very weak steroid on your hand, but use it cautiously and be aware and to inform the patient how to use it. We can use it and stop it, and just use it with very much caution. Sometimes kicking in antifungals in the form of oral. I prefer the oral antifungal. Sometimes it helps curb the infection, and it has been reported. So when to interfere? Now, we know that 50% will end up with keratoplasty, and we know keratoplasty can be therapeutic if there's a fulminant infection. We're not controlling, and we have to just cut out this cornea and take it. The problem with this, and I don't like to rush to it, is that if I put a new cornea, first, if the infection is only in the anterior part, and I just sprayed the cyst in the angle, let's say, or just on the iris, and I left it there and I did not wash it, and then I went out, I put a new virgin cornea, and I put him on steroids, then there will be a battle between reinfection and or I just rushed into a treatment that could be delayed. I've never done that. I've never had to do a therapeutic keratoplasty that is urgent for a patient with acanthamoeba, because we always reached a stage of, alhamdulillah, until now, because there's a patient who is admitted now with acanthamoeba, a stage where I had to dig it out by surgery. What I do is I wait for scarring, I treat all the vicinity of the cornea, and then I do a visual PK to make sure that he comes with the best visual outcome. And I give anti-acanthamoeba drops, although it is very toxic to the cornea, that is new, with caution for a week, combined with topical steroids to prevent rejection of the cornea. Tectonic is when the globe integrity is breached, and we had perforation, especially if it is with a concomitant infection of herpes, or the inadvertent use of non-steroidal anti-inflammatory, which is a big taboo, a big no-no for any kind of infection, not acanthamoeba, because it is a silent killer, and the patient will come with just an open eye. So abstain from this no matter what. And this is the only case that you need to just put a patch, whatever the case is. As I said, the concerns are the incomplete eradication, reinfection from the existing of the amoeba. The problem with the steroid is that it exists, the amoeba, okay? And the use of the steroid to contain the new graft, and we have always to balance risks and risks. Now, after that comes managing the sequelae, the cataract, and how to deal with it. The scleritis, as you said, it's rare, the anterior synechia, where we need, and the glaucoma, and I always give patients with severe infection anti-glaucoma treatment, because then the inflammation definitely hits the angle and would cause, even if it's an inflammatory spike in intraocular pressure, to decrease the aqueous flow that would also put a pressure on the cornea, and this will decrease the risk of melting or perforation. We reported a case of acanthamoeba keratitis with a candida that was in a young female who came to us with all the picture of acanthamoeba. We took 3 cultures that proved negative, and we had to import PHMB from Moorfields for that girl. And I went back because I was so sure this is acanthamoeba. And I took a biopsy deep enough, a 3mm biopsy below the eyelid to be covered, deep enough. And you cannot imagine how deep I went, just above the decimate, to take a specimen to make sure that there was a cyst, and it came full of acanthamoebic cysts. And the girl, she's married now, actually, that was years ago. And we had treated her, and she went into scarring, then cataract, and She went into keratoplasty cataract, and now her vision is 612 and living a great life. And this is one of, and she came back also with a candida infection. So we had to a candida and a camptoamoeba at the same time. This was one of the most difficult cases I had to manage. Last but not least, it's important to spot the patient early, because this can be a game changer in his life. As my friend Dr. Tahsin, that I always quote him because he's now the major supplier of anti-camptoamoeba treatment all my patients in Jordan. I had to say that he changed the lives of my patients as I changed his life. So good luck, and I'm ready for any questions. Thank you.
Thank you very much, Dr. Nancy, for this excellent presentation. And I think we need to go for, because we are running behind the time, so we can have the question at the end, if there is a time. Actually, we are running very late. We can have Dr. Murad, his presentation. I don't know, Dr. Murad may be here, but let's share his recorded presentation. Can you move?
Hello everyone, it's my pleasure to present about fungal. The incidence of fungal keratitis varies with climate. The fungal keratitis is more common in tropical regions. For example, in the US, the fungal keratitis account for 20 to 36% of microbial keratitis in the southern states, while around 1 to 5% in the northern states. The situation is almost similar in Europe, around 5%, while in Africa can go up to 37% in Ghana and 30 to 50% in India. In UAE, our center is a tertiary center where complex infections refer to us, so we got a percentage of around 18%. There are more than 250,000 fungal species has been identified, but only fewer than 100 has been associated with fungal keratitis. I want to highlight in this slide the important fungal infections. We can classify them, or the most important ones are either yeast or mold or filamentous. Yeast infection is mainly Candida keratitis, which is associated with chronic ocular surface disease, steroid use, and corneal grafts. On the other hand, filamentous fungi are the most common organism are Aspergillus, Fusarium, Acremonium, and Carvelaria. But if there is a history of trauma with soil or organic matter, it is most likely to be mold infection, while in the chronic ocular surface disease and prolonged steroid or antibiotic use, there is more chance of yeast infection. There are some distinct clinical features for fungal keratitis, like feathery margins, elevated edge, rough texture, satellite lesions, which are suggestive for filamentous fungal keratitis. Other features including endothelial plaque, a lack of corneal sensation, as well as gray-brown discoloration of the cornea for Carvelaria lunata. Previous report had showed that clinical examination and finding of multiple features can give you a high positive predictive value of fungal keratitis, around 83%. These features were serrated margin, raised slough, and color when it is not yellow. But multiple studies recently showed that it is not possible to differentiate clinically between suppurative bacterial keratitis and fungal keratitis. So the laboratory investigation is still the cornerstone for the diagnosis of fungal keratitis. Confocal microscopy is a useful tool if it is available, but it is operator dependent. The sensitivity can be as high as 88% and specificity of 91%. Corneal scraping is diagnostic as well as therapeutic, and fungi can be seen and identified in gram stain, but it's best to stain them with KIMSA, KOH, or calcifluor stain. Culture can take up to 1 week, and fungi can grow in blood or chocolate agar. It is best to culture them in sebaroid or HNB infusion and thioglycate broth. PCR can be useful, but sensitivity and specificity data is lacking. Biopsy is also useful, especially if there is if the culture is negative and there is a deep stromal infections that it's not responding with treatment. We all here agree that the treatment of fungal keratitis is difficult and the course can be very long. And the medication will depend on the availability of the medication as well as the course and the price of the medication. Sometimes you need a corneal transplant, especially in severe cases. Let's talk first about antifungal medications. First group is polines, which are natamycin and ephedrine B. Natamycin has a very good activity against most Fusarium, Aspergillus, but less effective against Candida species. It is the first-line therapy for fungal keratitis in the US. Amphotericin B is a first-line therapy for Candida species, has good to moderate activity against Aspergillus and Fusarium. Azoles, we have itraconazole, voriconazole, and fluconazole. Itraconazole has a good activity against Aspergillus, Candida species, but less effective against Fusarium. Voriconazole is almost the same, but less effective against Fusarium solani. Fluconazole is effective against yeast and has a minimal activity against filamentous fungi. Mucopurgin and caspofungin I haven't had any experience with, but it's also an option for fungal keratitis. This is a management algorithm. So whenever you have a smear suggestive of fungal elements, you can start the patient if you already know it is yeast or mold. So fluconazole 1% or amphotericin 0.15% is pharmacy prepared medication, fortified drops. So if you have it in your pharmacy, otherwise natamycin is a commercially available antifungal medication. Of course, if you have yeast, it's better to put the patient on amphotericin and plus minus voriconazole or fluconazole. For severe cases, you may add chlorhexidine 0.2%. For filamentary fungi, natamycin, or if you don't have natamycin available, you can use a combination of voriconazole and amphotericin. You can add also chlorhexidine 0.2%. If you identify the organism, you know that certain organisms have sensitivity to certain medication better than the other. These are some treatment considerations that you need to be aware for treatment of fungal keratitis. You need to hold the steroids and taper them quickly. You will see a lot of patients who have been on or misdiagnosed and have been on steroids. Epithelial debridement, as we said, it's therapeutic as well as diagnostic. Consider systemic antifungal for certain cases. Consider intracameral amphotericin for severe cases. Be aware of co-infections, especially bacterial superinfection. And consider early graft for severe cases and if there is no improvement within 7 to 10 days. This is a case of acrimonium. This unfortunate young woman has been putting herbal medication in her eye, and he presented late to us with this thick raised fungal growth in her eye. This is a case of an excellent example where debridement and scraping has been effective. This patient had 3 to 4 times scraping and debulking of this fungal infection. She has been put on combination of amphotericin and voriconazole, as well as systemic voriconazole. As you can see, there is a neovascularization. These three photos is taken 2 weeks apart from first presentation to the middle one, and then another 2 weeks for the last photo. The left photo is 6 months later, completely vascularized, but also completely resolved fungal keratitis, which was managed with Avastin as well as intrastromal cautery of these blood vessels. She had a full thickness corneal transplant, and vision has improved from light perception to 20/50 unaided vision. Let's talk about the treatment modalities that has been supported by evidence. Natamycin 5% was equivalent to iconazole 2%. Natamycin was superior to voriconazole, especially in cases of Fusarium keratitis. Intrastromal voriconazole and topical voriconazole no better than topical voriconazole alone. Same thing, systemic itraconazole did not add any benefit. Amphotericin B with subconjunctival fluconazole was better than topical amphotericin B alone. Chlorhexidine require a higher dose of 0.2%. Adding intracameral amphotericin in severe cases was beneficial. Adding also oral voriconazole in severe cases was not beneficial, but sub-analysis showed some benefit in Fusarium cases. Cross-linking as a treatment has been controversial. There are some case report which was beneficial, but this trial has been stopped because of high perforation rate in the treatment group, which was around 60%. So I'm more reluctant for cross-linking for fungal cases. These are few surgical considerations. You need to have 2 millimeter clear margin. You need to remove lens material, iris, if needed, if there is any infection. As we said earlier, amphotericin intracameral has been proven to be beneficial. Be aware that there is high rate of recurrence. This is a case of Fusarium solani. This unfortunate gentleman was presented to us quite late. He was admitted and started on a combination of voriconazole and amphotericin. And while waiting for a tectonic graft to arrive from the US, he told the nurses that something came off his eye, and now he could see the light much better. He showed us this material, which ended up being his natural lens, and we were actually seeing his vitreous when we examined him. Luckily, we could save his globe. We were actually lucky to save the globe. I did a corneoscleral graft of around 13 millimeter and suture to the sclera. Vision, he had some vision in this eye of 2400 and remained aphakic. All right, this is the summary. Stop topical steroid, scrape and debride the cornea. It is diagnostic as well as therapeutic. Topical natamycin is the first line for mold infections. Amphotericin voriconazole is for yeast. Consider dual therapy for severe cases by adding chlorhexidine 0.2%. Voriconazole oral or any other systemic antifungal might be beneficial for severe cases. Early surgery if there is any progression, especially for filamentous fungi. Then you can start steroid as early as 2 weeks post-op. Cyclosporin to control inflammation, and doxycycline to reduce the risk of melt. Thank you for listening, and have a great evening.
Thank you very much for Dr. Murad for his nice and excellent presentation and covering the fungal related corneal ulcer. I think we can have a few minutes for discussions. Before that, I would like to ask to Dr. Safwan if he's having any comments or questions to our speakers, Dr. Muhammad, Dr. Nancy, and Dr. Murad. I think Dr. Murad, he is also with us. Yes.
عليكم
دكتور
دكتور
مراد.
محمد.
عليكم السلام على
دكتور
دكتور
مراد.
مراد. حيا الله
Sorry
دكتور
for
مراد.
the being late. I
أيوة.
had a social commitment, and I have to record my presentation. Thanks for sharing it, Dr. Mohammed.
No, thank you very much, Dr. Murad. Thanks a lot. Okay, Dr. Safwan,
So
if you
just
have
taking the
question,
time
please.
because we are running the time. So definitely we will go to a few comments to Dr. Muhammad Husni. Excellent presentation with the remark on all the advances in the treatment. And I will start with the fluoroquinolone because I'm seeing a lot of patients that they are started with fortified before even the result of the culture. So fluoroquinolone that we need to highlight to all the audience, it's the start. And I just strongly hand to your hand that we need to start with the fluoroquinolone because it's a it's a broad spectrum and bactericidal and covering the Pseudomonas and streptococcal. So as a part of the gram positive, and the ability of the penetration to the cornea is very high. So I'm strongly with you for that. Second issues. I'm very
So
sorry.
Safwan, if you
on the
just
time.
allow me to interrupt you, for how long you can wait for the drugs? I mean, fluoroquine.
No, that's a question we can ask to Dr. Muhammad. The start
Okay.
is with the fluoroquinolone until the culture. That's the things that personally I'm doing it. I don't know the
Okay,
protocol.
can we have a comment very fast from Dr. Muhammad? What do you think? For how long you continue on fluoroquinolone before you move to, I mean, fortified, or you will put together? What is your opinion?
As
Or
long as the patient is going uphill, I continue with my treatment because I know I am on the right track. The thing is, sometimes you start on treatment and after 48 hours, you don't see any improvement. And sometimes the patient is going definitely downhill. Then you have to switch the treatment and go to another line of treatment.
That's what I'm saying, is that the start with for example, a fortified tobramycin is not the right choice here. Fluoroquinolone as a monotherapy is much better than going through. The second line, because saving time, going to the betadine. Now, you mentioned a very important point that we need to highlight it here as the betadine. I'm using betadine as an essential for, let us say, for example, 15 minutes, not as a drop, but I'm seeing and I'm reading and I'm reading a lot of published that they are giving as a drops. And in my opinion, it's carry a little bit some toxicity to the side. But when I'm starting with the betadine, it gives me a very good result. So what's your opinion?
I definitely use betadine in most of my cases. I think it's God sent. It
So
really.
you are using it as a drops.
5%. 5%.
what is the percentage? What is the percentage?
3%.
Sorry,
3%. Yeah.
3%. Okay.
So what we are doing actually is that we are, once I'm seeing the patient, I'm starting for every 2-3 minutes as a drops and up to 15 to 20 minutes in the clinic, and it gives me a very good result. Anyway, now the third issue that you mentioned is the cross-link, and we need to highlight the point of the cross-link that adjunct treatment and or monotherapy. So when you are starting the cross-linking, when you think that you need to start the cross-linking, in your cases, definitely.
Okay, now this is something that really needs a lot of time to explain. Yeah. Now, I have been involved very, very actively, and it's under publication now with the Swiss cross-linking study. They have actually made us use it as a monotherapy, and we have published before that the results of our combined therapy. The thing is, if you are going to use cross-linking, then you have to choose the cornea that you will cross-link, which means you should not have a cornea which is thinner than 250 microns. And this is something which is extremely important. We have used actually cross-linking with fungal infections, unlike the opinion of Dr. Murad. And we've had wonderful results with our fungal infections, provided that the cornea was not 100% thickness involved, and that the remaining cornea was much more than 250. We used cross-linking aggressively. We did the Dresden's protocol, and I can say that we do have quite a bit of results that encourage us.
So you are scraping and you are taking the sample for the culture, and then you start the cross-linking, or you start the medication and then cross-linking? That's my question.
I start the medication. If I don't find any improvement within the next 24 to 48 hours, then I will definitely consider PEC-CXL.
Okay, now back to Dr. Nancy, just to save the time.
Before you go, Doctor, if you allow me, Dr. Safwan, for the management, if you can please download or put the link for certificate in the chat, and all the participants, they can just click on the link and get their certificate immediately. Okay, Dr. Safwan, yes.
So Dr. Nancy, you mentioned a few things related to the chlorhexidine and the difficulties, and unfortunately we all had these difficulties, and I think that Murad, he shared with us, because I'm sharing with him a few cases, and one of the cases is still between me and Dr. Murad. Now chlorhexidine, what we are using is, just you said that we are using it from the mouth wash because that's what's available. And I tried with all material. It's very difficult to import it to UAE, and because all of it needs registration. So the only one is that with the mouthwash. That's why we are using it. But I didn't see any complication that you mentioned. So do you have any special experience with that?
I've stopped using chlorhexidine. Actually, I just used it for like 3 or 4 patients years ago, and I saw toxicity of the cornea that's so bad. So I stopped using it. Maybe one of the patients had scleritis that complicated the picture. He was immunocompromised, and that added to the very ugly picture that I saw. So I just abstained. Now I was very lucky to have the PHMB and Broline at my hand or at my dispense whenever I need it. I can also send it to you if you want. I have
Broline. We have Broline. We have fully prepared.
Is a game changer. You can use Broline with the chlorhexidine. Now, chlorhexidine start hourly and then go as fast as possible to minimum, because at a concentration of 0.02%, it's for the mouth. It's not a fashion to be for the eye, actually, or the eye tissue. I explain it that way. It's not gentle, and it's toxic enough when it's for the eye. So So
there is any there are different concentration or only one available?
Dr. Muhammad,
yes, we are preparing Dr. Muhammad.
To prepare it down to 0.02%.
Okay. So we got.
Yes, Dr. Murad, go ahead, please.
So in our center, I'm not sure. I don't think they get preparing it from the mouthwash. So our pharmacy, they imported a big amount, and they are using it to dilute it. So for severe bronchial infection, you can increase the percentage to 0.2%.
That's right, Dr. Murad, but that's in the government hospital. It's not available. This luxury things we don't have in the private.
You can ask Dr. Murad, he will send to you, Dr. Safwan.
But it's not, because I asked Tuam and I asked
no, you can ask Dr. Murad. I know he will help. Don't worry.
Anyway.
Okay, Dr. Safwan, before you move to this one, I want
the third
just
part,
1 minute.
Just to save the time, is that when you decide to do the PK patient, epithelial covered, still there is a peripheral vascularization, intrastromal, and patient having cataract and fully epithelial covered. So is that the time for PKP?
The question is for me, yeah?
Yes.
Yes, sure. It's now about, still.
Yeah, okay. So is there an active, I don't care if the epithelium is covered or not. Is it an active infection? Is the patient in pain? Is it getting worse? Or is it just an infiltrate that's not moving a lot from the beginning, but clinically might be better, the patient? As long as there's vascularization, I wouldn't think of a PK, but also it depends on why am I doing the PK? Is it to debulk the organism and remove it out of the eye because I'm not controlling it by the drops? Or is it because I want to regain the visual potential of the eye? So
no, it's only visual rehabilitation. Visual rehabilitation.
I wouldn't touch it before I'm sure that the eye is quiet for at least 3 months.
3 months.
I wouldn't touch it. Yeah, I wouldn't touch. And as long I treat the vessels, if the eye is quiet, is going into scarring, I treat the vessels with at least 3 sessions of anti-VEGF subcont or intrastromal Avastin before I touch the cornea for a PK.
Okay.
Okay, Dr. Safwan, if you can, yeah. For Dr. Murad.
Yes, thank you, Dr. Muhammad.
Can I just add one thing? Yeah.
Sorry?
Concerning the PK, important thing, it's very important if the crystalline lens is there or not. My rush into a PK differs. I wouldn't rush, even if it is an emergency, to a PK if the eye has no crystalline lens. The lens forms a barrier to my whatever I'm doing in the anterior part of the eye. So I wouldn't push any kind of infection or organism posteriorly. So this kind of judges also my intervention. So I just wanted to mention this.
Okay, just one small note. There is a lot of question regarding the certificate. Please, you can go directly to the chat box and you will find the link is shared there. If not, please, the management event, can you share the link in the chat box? It is available there. Okay. Okay,
One
Dr.
question
Safwan,
I have.
Just
One
to
question.
answer the question of Dr. To comment on Dr. Hosni, and
I was planning to keep this one for you to the end, but okay, if you do it, okay, go ahead.
All right. So the first point about the practice here for acanthamoeba, unfortunately, we don't have the luxury of having PHMB. So our protocol is a combination of proline and chlorhexidine.
Yes.
I agree. There is now even a new report increasing the percentage of PHMB is also useful. But inshallah, this is something we can look for and try to introduce it here in UAE. The second point is about the cross-linking and fungal infections. I agree with you, Dr. Muhammad, and we are looking for more publication and more evidence to support us to do fungal cross-linking for fungal keratitis. But as we say, the risk of perforation is high. We still don't know which cases to do and which is not. We have a very good outcome with certain case reports of cross-linking and good outcomes of cross-linking in fungal keratitis. But at the same time, we don't know if those people will benefit from the topical medication itself. So I feel like we are exposing them to the risk of perforation if they are already responding to the topical antifungal medication.
Dr. Muhammad, if you have a comment.
My response, I think, Murad, the more you do it, the more you will be much more encouraged to do it. I do have case presentations, based presentation on the fungal infections and PAC-CXL. And there are a series of patients, more than 57, I think. It's 52 or 57, I cannot recall off the top of my mind. And we all did them. They were either mixed infections with a fungal element or pure fungal infections. We've done cross-linking for them, PAC-CXL. We've included them in the PAC-CXL study, the Swiss study with Feri Hafizi, and we had really very good results. Actually, it was a big project between Cairo University and Zaazir University, and we really like the technique and like the results.
Looking forward to read it.
Okay.
Just a quick question for Dr. Murad.
Yes.
Hi. Dr. Murad, except for SKMC, because of the COVID situation, the acanthamoeba medication anywhere else available in the Dubai and this side, because sometimes we do get these cases and we feel very incapacitated.
I am, to be honest with you, not sure, but I got certain cases from Northern Emirates referred to me. Sometimes just for medication, they carry on with the follow-up with their primary ophthalmologist. I see them like cases with Dr. Safwan occasionally, and when they need a corneal transplant, I can transplant them.
Yeah, unfortunately, I searched all the UAE Emirates and we don't have it available. So I imported, and it was a long time for one case. That's why I decided to switch to the mouthwash, because it's the easiest end. And I didn't have any complication with it. Actually, with all my cases, I have few cases now with the acanthamoeba, and they are doing very well. Only one case that she came late, and now it's running with Dr. Murad for PKP. But otherwise, the easiest case that started with, it's that it was in the epithelial level, and deepthelialization within 2 weeks, everything was done. And the other cases, it was an intermediate, so it didn't need any interference. But this case that it's still now, she has full epithelialization, by the way, Murad. I saw her 2 days back, and she's doing very well, but unfortunately the cornea is all opaque, and she's been diagnosed by herpetic and treated as a herpetic, and then switched to the steroid, and then end up with the disaster. Anyway,
okay, can we
thanks for all.
finish the other, please? I have several questions here, so let's go through of them, and we have can we have a very fast and short answer, if you allow me? Do you have any experience with corneal biopsy? What is the technique? Okay, Dr. Muhammad, if you can give us a very fast, within 30 seconds or less, please.
Actually, Dr. Sandeep Mitra did this.
Yeah, I can refer to him this question.
If you can use the trephines, the dermatologically the dermatology trephines, the millimeter trephines, and you get a good. I'm not a very big fan of corneal biopsy, though. I haven't seen any problem with corneal scrapings over the past like 20 years. But then you can do a corneal biopsy using the trephines used in dermatology. I use the 2 millimeter trephine. I don't like using bigger ones like the 3 millimeter ones.
Okay. I think this question also, the second one is for you, Dr. Muhammad. How soon would, I think this one you already answered, Dr. Safwan, he asked. Okay. What is the role of corneal biopsy in such cases? Would it be better than scraping, since we have to go deep? I think this one, it is for Dr. Nancy.
What is the role of corneal biopsy? Now, if you have the clinical picture, actually, which all points out to acanthamoeba, you can just go ahead and start treatment. If I go aggressive with treatment, which is with the sampling, which is mainly scraping, that I go deep, remove the epithelium, debride it, and I go deep. If it's a late stage, if not, if it came back negative and I want to justify my treatment, which means I need to import drops or tell the patient that there's a long way to go, or to justify that there might be a possibility of, and the poor prognosis, then I would do a biopsy. I don't go for biopsy straight away unless there's a very yeah, that's it. And the technique, as we said, is just above, so it's covered by the lid margin and very small sample.
Thank you very much, Dr. Nancy. The last one is, I think we talk about, but if someone can just give a hint about it, how to prepare the chlorhexidine drops from the mouthwash. I asked this question actually, but I think the people, they didn't get.
It's depend, if you allow me, it's depend on the concentration that we need. If it is 0.02, then we will take 1.5 cc from the mouthwash, and replace it by 1.5 cc from the artificial tear. And if we need 0.04, so it will be 3 cc.
Okay, the last one, we have also one last question. What is the protocol of bovidine iodine drops in bacterial keratitis? How often and for how long? I think this is also
Mohammed Husni.
4 times a day for as long as it takes.
Yeah.
How do you, okay. How do you, in 3%, okay.
3%.
3%. Okay, I think I want to say only one thing, that corneal ulcer is a very big topic. We cannot cover everything in this. Even we run 2.5 hours. I didn't anticipate to go further like this period. I was thinking by 10:30 we'll finish. As I talked with Dr. Murad, by 10:40 we will just discuss. But I think the topic is very important, and we need maybe another sessions that to cover. Even I remove the viral corneal ulcer from this session, because I think it will take a more long. But anyway, it was an excellent. Thank you for all of you. Thanks, Dr. Muhammad, Dr. Nancy, Dr. Murad, Dr. Safwan, and Dr. Sandeep. Very special for him, because I give him the task in the last minute. And Dr. Hayat, thanks for all your input in this session. And we hope to see you inshallah soon. Just for the last one things, comment or not comment, only an announcement, sorry. We are now preparing for the third MEOM, which will be on 23 and 24 and 25 of September. And we hope that we see you all also in like these sessions, talking about the corneal ulcer or other materials. And we hope that I will, inshallah, send for you a special invitation for regarding this soon, inshallah. Thanks for you all, and goodbye. See you, inshallah. Assalamu alaikum.
Thank you so
Thank
much.
you.
Assalamu alaikum.
شكرا دكتور مراد انك حضرت بالاخير. Thank you very much.
This the certificates are very fast. It's already here. Just for
okay, so the people, they are not seeing, but I think it is there. So please, the link is uploaded in the chat box. It is uploaded in the chat box. Go there and just click on that link, and you can have the